It's a real pleasure, and I'm very honoured to be invited to speak to you today with my colleague Daisy Cam. So I'll just start off with my disclosures. Now, I've been asked to talk about obstetrics and MS, and obviously this is a really large topic, very difficult to kind of cover everything in detail in a very short period of time, but we would like to give you a bit of an update about MS and pregnancy, family planning and MS DMTs and breastfeeding in MS, and we'd like to talk to you about our joint MS and pregnancy clinic in Sheffield. So I'm one of the MS consultants in Sheffield. So just to start off with a bit of a background, we all know that multiple sclerosis is 3 times more common in women. Mean age of onset is 30 years, and more than 50% of women with MS will develop the disease during their reproductive years. Most women will not have completed their families at the time of diagnosis, and hence pregnancy issues are understandably a very important issue for these patients. If we look at the historical view, Gower has described in his textbook, I have known it, multiple sclerosis, to begin during pregnancy, remain stationary until the next pregnancy, and then become progressive. So historically, women with MS were actually advised to defer treatment until they completed their families. Indeed, women were discouraged from falling pregnancies, and termination of pregnancies was found to be higher in MS. So it was up until 1998 when the PRIM study really changed our view about the course of pregnancy in patients with MS. And indeed, and I'm sure you'll be all familiar with this study, and it has shown that actually the rate of pregnancy rate of relapses in MS does decline during pregnancy, particularly in the 3rd trimester, where it then increases during the first 3 months postpartum and then reverts back to the pre-pregnancy rate. When we look at the modern cohorts, overall, the pregnancy rate, the relapse rates were actually found to be lower, but we still see the trend of a reduction in the pregnancy relapse rates particularly during the 3rd trimester, and then an increased risk in the postpartum period. So what are the challenges that are faced between patients and the physicians when managing pregnancy and MS? Now, currently, there are no randomized control trials to study disease-modifying therapies in pregnancy. There's limited trial evidence to inform management through pregnancy and the postpartum. Pregnancy registries provide some safety data, but they do lack control groups, and they're usually slow to recruit. And previously, women had to defer starting their treatment until they completed their families. In women whose conception takes longer than anticipated, there is a potential lead to a significant delay in starting treatment. And indeed, some studies have shown that up to 40% of women of MS are not on a DMT 12 months prior to pregnancy. Now, we know time is brain. There's a wealth of evidence to suggest that actually MS starts well before the time of onset of diagnosis. And it's not just the inflammatory component in patients with relapsing remittent MS, but also it's the degenerative component of the disease that starts very early. So there's a wealth of evidence that we should be hitting MS hard very early on the disease. Now, this brings us to a dilemma. Now, there are evolving MS diagnostic criteria, meaning earlier diagnosis. That means more people with MS will start treatment soon after diagnosis. And the dilemma is what to do when a patient wants to become pregnant while taking disease-modifying therapies, or becomes pregnant while taking treatment. And women will have to face a choice between early resumption of DMT and postpartum during the postpartum period, or breastfeeding. So we know that family planning in patients with MS is really key to improve their overall outcome. The WHO defines family planning as the ability of individuals and couples to anticipate and attain their desired number of children and the spacing and time of their births. It is achieved through the use of contraceptive methods and the treatment of involuntary infertility. Family planning is really planning the future. But what does the future hold for a patient with MS, particularly those who are newly diagnosed? Patients will have to cope with a new lifelong diagnosis, uncertainty about the prognosis. We advise them to do undertake lots of lifestyle modifications. But they also have to cope with the decision on disease-modifying therapy. They have concerns about the safety of treatment in pregnancy. They have to face the choice of breastfeeding or starting treatment. They also have to make decisions about what type of treatments they want to start. Do I start on a tablet, or do I start an injection or an infusion? So this is a very, very challenging time and very difficult decisions for patients to make. Looking at the studies surveys that asked women with MS on the knowledge on pregnancy and MS. So the surveys have identified a lack of available and reliable information for these patients. Patients felt that there was a lot of conflicting advice. There was a lot of uncertainty about the course of their MS and the effect of the pregnancy on the disease. This survey showed a low awareness of teratogenicity risk of DMTs. There was 10% of these patients actually had unplanned pregnancies. And then in this recent survey showed actually MS significantly impacted family planning decision in patients with MS. And indeed, people with MS are significantly less likely to have children in comparison with the general population, and less than 25% considered family planning when selecting a DMT. And indeed, there's a significant proportion, about 14% of them, who actually decided against having children, and 7% delayed their plans. And the main concerns were the risk of their MS worsening or the risk of harm to the baby. So these kind of surveys just kind of tell us about how much the patients, they don't have enough information, or they're not being counselled enough about the pregnancy and management of pregnancy in their MS. Now, when we look at the prevalence of unplanned pregnancy, 16.2% are unplanned, 29% are ambivalent, and 54% are planned. But 2/3 of the unplanned pregnancies occur in women aged 20 to 34, and this is the age where patients with MS are diagnosed. Now, why is this concerning? Is because most of our patients, when they do fall pregnant, they tell us when they're about 6 to 8 weeks. And this is the time where the baby starts to develop. In fact, all of the vital organs, the CNS, the heart, the eye, this is the time where they start to develop. So if they are on a DMT, which is teratogenic, they come to tell us at 8 weeks, the damage might have already been done. At the time for planned pregnancies, when studies have looked at it, 16% of patients don't get pregnant in 1 year and 8% don't get pregnant in 2 years. So this is quite a significant proportion and quite a long time for patients to delay starting treatment if they're planning pregnancies. And we know that a woman's chance of successfully conceiving tightly correlates with age. So if the longer they leave their decisions to start to have a family, the less likely is that they can get pregnant. Now, it's also important that we counsel our patients about the outcomes of a normal pregnancy. 1 in 4 pregnancies will end in a miscarriage. In America, 1 in 33 babies are born with birth defects. So it's really important that our patients are aware of that these are just the outcomes of normal pregnancy, and not just to put it all down to MS. So counselling should start really pre-pregnancy. We should consider pregnancy very early at the time of DMT choice. Switching disease-modifying therapies can lead to relapses and rebound disease activity with DMTs that require a washout period. And pre-pregnancy relapse rate is associated with an increased risk of postpartum relapses and long-term disability. So ideally, we should be aiming for disease stability prior to pregnancy. So when we speak to our patients and discuss about family planning, it's obviously very important to discuss disease-modifying therapies. When we sit in an MSMDT, this is what we discuss, and I'm sure you're all familiar with it, but we have to consider all these factors and take it into consideration. But pregnancy is a very important factor. Now, in the last decade or so, there has been an exponential increase in the number of DMTs, and this doesn't only make it challenging for patients, but it also makes it challenging for us as MS consultants to discuss with our patients. The timing of family planning opportunities varies with the DMT, so it's important to just take the DMT washout periods and bear that in mind. In general, interferons, glatiramer acid and natalizumab are considered to be safe during pregnancy with the current evidence, as well as breastfeeding. Dimethyl fumarate can be taken up to conception, but it's contraindicated during pregnancy. However, all of these other disease-modifying therapies, we have to take into account their washout period. Now, this study looks at the impact of stopping disease-modifying therapies prior to pregnancy, and this is the data from the MS-based registry. And this looked into patients who were taking natalizumab, which is a high efficacious treatment, fingolimod and DMF as moderate efficacy treatment. And what the data showed is that intrapartum and postpartum relapse rates increased among women who stopped treatment after having these high or moderate efficacy treatment. And indeed, it showed that pregnancy itself is not sufficient enough to control the relapse rate in women with highly active MS. And this is another study which looked into patients who were taking natalizumab and stopped it early, either before pregnancy or early in the first trimester. And it did show that early pregnancy-related DMT cessation may be associated with an increased risk of postpartum relapses and disability progression. Recently, in the last couple of years, fingolimod, which is one of the moderately effective therapies, but it's also contraindicated in pregnancy because of its risk of congenital malformations. It has been approved for children and adolescents. That concerns me a lot, just because this is a group where we would expect unplanned pregnancy. So it's really important that we make sure that this cohort of patients are well aware of the teratogenic risk. But also, they need to be aware that stopping fingolimod can really cause very disabling rebound relapses. Now, patients would want to know what are the predictors of intrapartum relapses, and so far the evidence suggests that a high preconception relapse rate, being on natalizumab or fingolimod, stopping them early before pregnancy or in the first trimester, can lead to relapses during pregnancy. The predictors of postpartum relapse, the strongest predictor is preconception relapses, but intrapartum relapses and a high disability score at conception increases the risk. Exclusive breastfeeding, continuing natalizumab throughout pregnancy, and reinitiating high efficacy treatment during early on in the postpartum period are found to be protective. Postpartum disability progression is shown to be associated with a higher relapse rate during pregnancy and relapse recurrent postpartum. So overall, the prevention of relapses as well as subclinical activity remains an important goal to prevent subsequent disability accrual. Now, relapses can happen and may occur during pregnancy or in the postpartum period. They are treated with steroids. There has been some literature upon the risks with steroids and cleft palate, but the risk is now less. Now there's less evidence for this. There has been associations between babies exposed to steroids during pregnancy and mental and behavioural disorders. However, we use methylprednisolone to treat relapses, which does not cross the placenta to significant effect. So we don't think it's associated with these risks. Severe relapses that are not responsive to steroids, they can be treated with plasma exchange. So moving on to breastfeeding and family planning, we know that the potential long-term health benefits of breastfeeding to the mother and baby are very well documented. A positive impact on reducing postpartum relapses has been established, and we should be encouraging women to breastfeed. Now, systemic reviews and meta-analysis have shown that breastfeeding was associated with a reduced risk of postpartum relapses, as well as other prospective studies from Germany. And the effect of breastfeeding is particularly strong with exclusive breastfeeding and those women who had a higher pre-pregnancy relapse rate. Now, the decision of breastfeeding must always be assessed on a case-by-case basis. Women should be supported in decision-making according to their individual circumstances. They should know that DMTs and breastfeeding are not mutually exclusive. Treatment resumption after the delivery should be discussed with the mother with a risk-based stratification approach. It's always good practice to check for disease activity shortly after pregnancy with neuroimaging, because this can inform us and help us in our decision-making. Now, as a general guide, patients who are at low risk of postpartum relapses, so those who have had no relapses in the year prior to pregnancy and no disease activity on MRI, they can be encouraged to exclusively breastfeed up to 6 months and then resume DMTs thereafter. Or, if should they wish, they can use interferons or glatiramer acetate. Those with intermediate risk for postpartum relapses, we would encourage them to start treatment as soon as possible after delivery. Patients who are at high risk are those who have had multiple relapses in the pre-pregnancy year or who have had relapses during pregnancy or active MRI scans. We would recommend them to start treatment immediately in the postpartum period, typically between 2 to 4 weeks after delivery. Now, for those who wish to breastfeed, monoclonal antibodies could be considered, such as natalizumab or anti-CD20 therapies. These monoclonal antibodies have a rapid onset of action, predominantly IgGs. They do not pass in significant amounts into the breast milk, and they are generally poorly absorbed by the baby's GIT. Now, this study has shown that the transfer of monoclonal antibodies into breast milk is actually about less than 2%, and the relative infant dose of less than 10% is usually considered safe for breastfeeding. So this is encouraging. However, there is always a word of caution. So using anti-CD20 therapies very early on postpartum period can lead to immunosuppression in the baby. And so the live vaccinations, such as the BCG or the rotavirus, should be deferred for at least 6 months after the last dose, because there have been case reports of fatal outcomes after a BCG in babies exposed to monoclonal antibodies. This is the recent guidelines that has just been published about the use of anti-CD20 therapies in pregnancy and breastfeeding. And I have to say, they're very encouraging, and the guidelines now suggest that we can actually advise women to conceive within 3 months from the last dose of either ocrelizumab or ofatumumab. And there is also some safety data about their use in breastfeeding. Another strategy that can be used to manage our patients is to use induction therapies. So these are treatments that would provide a long-lasting disease control and would minimize DMT exposure during breastfeeding and during pregnancy and breastfeeding. And these would include the anti-CD20 therapies, cladribine or alemtuzumab. However, with alemtuzumab, there is a risk of autoimmune thyroid disease, so thyroid function monitoring must continue during pregnancy. Now, in the last couple of years, the ABN guidelines have put together very nicely a really nice, very clear guideline on how to manage pregnancy in patients with MS. And I really find this it's not just helpful for us as healthcare professionals, but it's also helpful for the patients as well. And these guidelines have been updated, so it just shows how quickly the evidence changes over time. Now, a very interesting statement in the guidelines is the creation of joint neuro-obstetric clinics to allow for the best multidisciplinary care for our pregnant MS patients. So we were sat in one of our MS service meetings, so I'm sure we've had a lot to discuss on that. But this is where the idea of having a joint obstetric clinic came up. It's after the guidelines, we felt that actually having a joint clinic to provide the best care we can for our patients. And this is where we've decided to establish the Sheffield MS Pregnancy Clinic, and I will hand you over to Daisy, who will talk to you about the clinic. Thank you.
Thanks. So, why did we decide to have a Sheffield MS Pregnancy Clinic? As Azza said, we have a huge amount of young women and men with MS, so we felt that it was a really important thing to establish and run. The idea behind it was to encourage and facilitate family planning discussions pre-conception, as has already covered, to also develop a comprehensive plan of management during pregnancy and labour, and to develop a comprehensive management plan and advice for the immediate postpartum period. So one of the registrars at the time, who's now a consultant, established these guidelines. So this is just a flow chart of what we do in Sheffield for our MS patients who are thinking about pregnancy or who are pregnant. It's quite straightforward. and it speaks for itself, really. So where does the role of the MS nurse come in with these patients? So I think we should all be asking all of our patients of childbearing age, every time we see them, if they're thinking about a pregnancy at every appointment. We need to inform the patients of the preconception and pregnancy clinic that we run, so they can then let us know if they are thinking about pregnancy or are pregnant. We should ask them to inform ourselves or their neurologist as soon as they become pregnant. And if necessary, we need to stop their DMT and counsel them appropriately as to what happens next. So this is the Sheffield model. We established 2 clinics. One was a preconception clinic and one was a pregnancy clinic. So how we run the preconception clinic is myself, Dr. Ismail, and Dr. Bonnet, who is a consultant obstetrician, got together, had a few meetings, had a bit of planning, and decided to set this up. Dr. Bonnet is a obstetrician with an interest in maternal medicine and also has an interest in neurology and currently runs the epilepsy pregnancy clinic, which is where we took the model from. So anybody who's considering pregnancy will be referred to this clinic by either their own consultant or the MS nurse. We see them in that clinic jointly, the 3 of us, and we take a history of their previous pregnancies. We take a history of the medications they're currently on and history if they're on a DMT and discuss whether we need to switch that or come off it or stay on it. We give them preconception advice, and then we tell all potential parents about the registering on the MS pregnancy register. The website is on the slide, and I'll go on to that in a little while. We run this clinic 3 times a year, but we know it's already full and we're going to have to extend that. The treatment decision-making in pregnant women is quite complicated, as I'm sure you're all aware. Azza sort of touched on that, all the different things that we need to take into account, which is what we cover in the preconception clinic. So the counselling that we would give at this point is that pregnancy and childbirth have no long-term effects on an individual's MS. Many women notice that their MS symptoms decrease during pregnancy, but we also know that the risk of relapse does increase somewhat during the first three months postpartum. We also notice that during pregnancy, with MS or not, there can be an increase of bladder, bowel and fatigue symptoms, which should resolve post-delivery for those MS patients. And in general, there's absolutely no reason why women with MS can't give birth or be an excellent parent, and we should actively encourage them to be so. Many patients worry that their children will also get MS. We know that there is a genetic aspect to MS, but it's no means the whole story, and MS is not directly inherited. So having MS does not affect fertility or the risk of miscarriage compared to the general population. It doesn't affect the long-term disability outcome. We need to discuss current MS medications, whether it's safe to continue through conception, pregnancy, and the postnatal period. As said, it may be necessary to switch the treatments to one that we know is safe. Advise not to defer starting on the DMT because they wish to have children. And relapses can be treated with methylprednisolone during pregnancy. So, what should I do before conceiving? We also give this advice because this is something that I've learned. I think both Azza and I have learned so much from Dr. Bonnet, and I think she's learned so much from us. And I think that's why having a joint model is so important. So start obviously taking folic acid 3 months prior to conceiving, and during the first 12 weeks of pregnancy, that can then be stopped. It doesn't have to be continued throughout the whole pregnancy. Take vitamin D per day for the entire pregnancy and beyond. Stop smoking, eat well, and assess the patient's BMI and advise about their weight. I think it can be a bit of a tricky one to bring up this, but I think when women are told that their BMI can actively affect their chances of fertility, they're more likely to do something for that rather than just not mentioning it. So the common questions that we get asked is, will I need extra growth scans? No, not because you have MS. There's no reason at all. Will I need a cesarean? No, not because you have MS, but it is a patient's choice. But we would not actively encourage that. Can I have all the pain relief in labour? Yes, you can. Can I breastfeed? Yes, women who want to breastfeed should be supported. And as has already said, exclusive breastfeeding may be beneficial in women with milder disease. Breastfeeding should not be discouraged in favour of resuming a DMT. And we know that interferon and glutamate acetate natalizumab are all safe in breastfeeding. In women who do not want to breastfeed, we encourage them, we want to start them very early on, 2 to 4 weeks post-delivery. If they've had a cesarean, we would leave it 6 weeks for them to recover, but we want them back on treatment ASAP. So the MS Pregnancy Clinic was set up at the same time. This was to encourage and facilitate family planning discussions, pre-conception counselling, to develop a comprehensive plan of management during pregnancy and labour, and to develop a comprehensive management plan and advice for the immediate postpartum period. So again, this is run by Dr. Ismail, Dr. Bonnet and myself. We have this once a month, and we see patients in their first trimester, their third trimester, and then once post-delivery with their baby. The drawbacks to this is that even though we cover a huge geographical area, we can only run this clinic for Sheffield patients because Dr. Bonnet is only Sheffield-based. So we're happy to see patients from outside Sheffield, but Dr. Bonnet can't get involved in these particular patients. We found that it's a really good way of joining up, working across different specialities. Patients have said they feel very well supported, and we have now had 11 babies, right through from pre-conception to bringing them back to see us after they've had them, which is lovely. So what we do in the first trimester when we first see them, early booking is really important to enable the formulation of a good management plan for their entire pregnancy. So what we do at that first appointment, we review their MS, we take a history, look at their medication, their symptom management, obviously tell them about the importance of getting any UTIs treated ASAP, vaccinations, as we've touched on, and discussion about DMTs. In that first trimester, obviously, there's also an obstetric review, dating scans, antenatal review, blood tests, etc., etc. We talk about induction of labour and caesarean sections, blah, blah, blah. So this is more the sort of maternal side, but it's all discussed at that appointment. When we see them again in the third trimester, we undertake an MS review, relapse review, medication review, symptom management. We have a plan for the post-delivery DMTs and also discuss breastfeeding. So the obstetric review side of things at the third trimester is an antenatal review, anaesthetic review, plan for mode of delivery and contraception. This is the MS Pregnancy Register that I mentioned. We really encourage all women across the UK to register on this. It was set up by Ruth Dobson and her colleagues, and it's anonymous, so they don't have to give any details, but it's just to capture information as to how many women with MS are pregnant, what treatments they're on, what treatments they've been on in the past, and it's just something, if we could all encourage our ladies to do this, that would be great. So at their postpartum review, when they come back with their babies, that's the rule, they have to come back with their babies, is we review their relapses, medication, symptom management, all the same things really. We discuss doing an MRI scan that we feel is quite important post-delivery to get them scanned to see if anything's changed during that 9-10 months. We discuss if they're breastfeeding, contraception, and then we discharge them back to their own MS consultant. So whilst pregnant, they're under Dr. Ismail, and then they will go back to their original consultant if they want to. So general advice for postpartum is there's no need to stop breastfeeding if methylprednisolone is required. Continue to take the vitamin D. Take all the help that you can from anybody that offers it. We know that there's evidence of an increased risk of depression in mothers and fathers with MS. And the MS teams need to be aware of this and look out for it and offer appropriate support and referral if necessary. So in Sheffield, we developed 2 different leaflets, one for the preconception clinic, one for the pregnancy clinic, and we encourage our consultants to give out the preconception clinic leaflets to all ladies of a certain age in case they do fall pregnant without planning, or if they're thinking about planning a pregnancy, they know just to call us and we can get them booked in. So the clinic checklists we've also developed, so these will go in the patient's notes, and it covers everything from pre-conception clinic through to the seeing them whilst pregnant and then their follow-up appointment after pregnancy. So in summary, family planning should be considered early in patients with MS. The benefits of DMTs should be weighed against the risks of the fetus or infant. Women with MS should be counselled about the risks of early cessation of stopping a DMT due to pregnancy. Women should be encouraged to breastfeed, but we should also support them if they don't wish to. DMTs and breastfeeding are not necessarily mutually exclusive, and we need to all encourage our ladies to sign up to the pregnancy register. That's it.